রান থ্রু দিয়ে তো প্রথমে গেল, তাই না? আর একটা পাইলট, একটা রান থ্রু ইনিশিয়ালি।
Thank you, sir, madam. We are now on YouTube live. Thank you, sir.
Already everybody joined with us, and welcome you all from this today's scientific session. Especially we must thank National Heart Foundation and today's operator, Professor Dr. Fazilatunisa Malik. Everybody actually known to her, and she's very renowned intervention cardiologist not in Bangladesh, whole world already, and she's chief consultant cardiologist of Department of Cardiology, National Heart Foundation, and deputy and director academic affairs, joint secretary, general secretary, National Heart Foundation, Bangladesh, and lot of actually word we can use, and but she is now institution like her father now. I must thanks Professor Fazilatunisa Malik, and our Vice Chancellor will join with us. So already our Professor Mir Jamal sir already joined with us, and other renowned cardiologists with us. But we'll be delighted if our Vice Chancellor
joined
with us, sir. I know sir is very busy schedule. So sir, I would like to offer our Vice Chancellor today's program chief guest. Then we'll go our other program, because sir is very busy. I've seen in the morning. So with all schedule we have, I first told sir, please say something as a chief guest of this program. This is a continuing program of National Heart Foundation and Bangladesh Cardiovascular Research Foundation. Please, Professor Sharfuddin sir is very dynamic Vice Chancellor of Bangladesh, and sir so busy with his busy schedule. Sir has given always this type of academic program, and I must thanks, and everybody knows already Professor Sharfuddin Ahmed is an excellent dynamic leader in the today's academic environment of Bangladesh, and we hope sir will give some our future direction with his fused language. Thank you, sir.
Thank you.
Professor Sharfuddin Ahmed, sir.
Thank you, Professor Mustafa Jaman. I am seeing my colleagues, Mominujjaman, Khondakar, Asadujjaman, Shohidul Haq, and other people are here. And I thank Dr. Professor Fazilatunisa Malik. Already you have mentioned about her that she is now like her father an institution. Today, there will be some intervention. As a intervention cardiologist, she is the famous one. And this live program, which is being already, it is broadcasting from National Heart Foundation. I am proud that I am also one of the chairperson of Gopalganj Heart Foundation. So I am also related with you. And I hope your activities, which is not only in Bangladesh, it is renowned all over the country and abroad. I hope the newcomer, they will be also efficient enough from your activities where you are performing your all types of intervention cardiology. I hope in our country, there is surgery, there is all sorts of investigation facility, there is also intervention. In all the institute, in Heart Foundation, in Bangabandhu Sheikh Mujib Medical University, and some of the medical colleges, they are performing it. The seniors who will disseminate their knowledge among the newcomers and the residents, I hope they will be eligible, they will be efficient enough to perform all these duties. All of our duties that if I work, my work should be disseminated to my researcher, my students, and I will be successful then when I will be able to make my assistant, my juniors, as my activities, they will be same. If we can do it, I hope our activities will be a successful one. I thank all the organizers for inviting me as the chief guest. I thank again Professor Faziluddin Malik, who is performing today's activities. With these few words, I will be always with you, and I hope in all the districts, this Heart Foundation will work very nicely as Brigadier Malik, who is the dream person, whose dream is now being implemented in all the countries. I wish him as a successful man, and I wish his good health, and life expectancy should be up to 100. And with these few words, thank you very much for inviting me here, and I will be always with you. With this, thank you very much. Joy Bangla, Joy Bangabandhu, Bangladesh, Chirojeevi.
Thank you, sir. Thank you for from your busy schedule. You have given some time, and you always encourage this type of academic environment and academic educational program. And we must thanks to you from Bangladesh Cardiovascular Research Foundation and National Heart Foundation also. And already many renowned cardiologists I have seen, Professor Mohammad Jaman and Professor Mir Jamal sir and other people, other cardiologists already joined. And with your permission, Professor Mohammad Sharafuddin sir, we'll start our today's session.
Thank you very much. You can start, and it should be started now. Thank you. I will leave now in another meeting. Okay. Thank you.
Sir. Thank you, sir. Thank you. Professor Faziluddin Malik, Madam, we can start. And Professor Mohammad Jaman, I have seen already joined with us, and Dr. Asad Jaman, Professor Sorabo Jaman, Professor Mir Jamal from Bogura, Professor Dr. Shohidul sir, Professor Amol Kumar Chaudhary. We could not mention all the name, but we'll continue if anytime we have found some our new colleagues or our newer interventional cardiologists. Professor Faziluddin Malik, please go ahead, please, madam. We are with us.
Assalamu alaikum, friends and colleagues. It's indeed a great honor and privilege for all of us who are in Heart Foundation and we work in the cath lab for this opportunity. And let me first give a brief introduction about Heart Foundation and about this case today, without further ado. So as you are aware, can we have the slides, please? So National Heart Foundation is a non-government, non-profit organization, and we have currently 480 beds totally dedicated to cardiac service, and this is a tertiary cardiac center. And we started doing main PCI from 2007 actually. And if we go to the next slide, you will see that up till August of this year, we've done near about 60,000 PCIs, of which left main PCI is almost 3,500. We've already crossed that limit. And now something about this patient. So this is a 65-year-old gentleman who has a long history of chronic stable angina. He's ETT positive. His ejection fraction is 64. Now, one thing that has not been mentioned here is that he has a serum creatinine of 1.5. So he has CKD and also he has a COPD. And considering everything, he was not at all keen to undergo CABG. So let's have a look at his angiogram. So his angiogram, can we run the pictures, please? So the left main, this angiogram was done actually in Sylhet. So he has a left main of 95 to 99% stenosis in its proximal segment, starting from the ostia. And then you can appreciate that there is heavy calcification through the entire length of the proximal and mid part of the LAD. The LAD is heavily calcified. LCX, we could not really ascertain what's happening because obviously the angiogram done is non-selective due to the severe stenosis. RCA also has a aortoosteal disease, 90 to 95% stenosis at its origin. So with this angiogram, how do we go and treat this patient? If you want to discuss, we can, or we can just show.
Tremendous case, and before starting your discussion, I would like to share that this program is already scientific partners in INSEPTA and Cardiovascular. And next step I will discuss. First, Dr. Ashok Shetty, you may add some.
No, I'm not Ashok Shetty. I'm Ashok Datta. Thank you, ma'am.
Close, Ashok, just Ashok, Shet or Datta. But Ashok's a great interventional cardiologist as well. Ashok Datta, I mean.
Thank you, ma'am.
Ashok Shet also, of course.
So both osteum are severely diseased, right coronary and left coronary. I have forgotten the age of the patient, ma'am.
65.
65. So definitively severely calcified left main, LAD proximal. LCX appears to be normal. RCA other than osteum is mid distal all are looking normal. So definitively rota is an option. And even after rota, such osteum of the left main, it is difficult to expand the stent. In that circumstances, do you think that cutting balloon or scoring balloon can help here?
So we haven't tried yet, but we
First option,
are willing
ma'am,
to
whether
see.
you will go to the right or left first.
So what is your opinion, Ashok? Which
So
one
right
should we
seems to be that is quite stable plaque.
right?
So even you, if you don't do the right, patient will remain asymptomatic if you tackle the left one with a good result. So I think left definitively you have started left, and for life the left is more interesting for the audience, I think.
Yes, so actually we also debated about this, what to do, where to start, and the general consensus among our team was that we should definitely start with the left side. The right side is, as you have rightly pointed out, relatively stable, and the LAD seems to be, the left main seems to be a subtotal occlusion, heavily calcified, almost 99% stenosis. And so we decided to start with the left. And actually, right at 11:30, we put our catheter. And then, as you can appreciate, we could not wait for much long. That's why we were saying that when will it start? So this is how it looks with our EBU catheter today. The left main is like 99% stenos, right? You can just barely see the dye going in. And then what we did is we wired the vessel. We wired the vessel first. We did a cuspal so that our catheter is not really jumping in or anything and causing further hypotension. So we've put a cuspal wire, and then we took a run-through floppy wire with the help of a fine cross micro catheter. And with that, we were able to wire the obtuse marginal as well as the, I think, so here, as you can see, a very gentle maneuver, and our wire goes into the obtuse marginal, and one went into the ramus. So two wires we now have, one in the obtuse marginal and one in the ramus. Then what we did it, we pulled back our wire, changed the angle, and after that, we were able to cannulate the LAD. So our wire is now, the run-through floppy wire is now in the LAD. We push our microcatheter down and exchange this wire for a rota wire, a rota floppy wire. So we change, and then we again put back our cuspal wire so that our catheter doesn't really go in. It's not going to go in, but still we do that. And then, so now we are in business. You can see the calcium, right? Angiographically huge amount of calcium, and the LAD is 99% stenos. We remove our cuspal wire. We take a 1.5 millimeter burr, and then we do rotablation. First, we do rotablation of the ostia of the left main. So this we did, and after doing rotablation of the ostia, we gave like 15 seconds run, and we take it's a 150,000 rotations. We then go a bit down again. Altogether, we did 4 runs, each ranging from 15 to 20 seconds each of the, and after 4 runs, I think we were quite satisfied with the result, and then we took a angio. So this is how the vessel looks now. And this is where we are right at this position. We had to do the rota, otherwise the patient was getting a bit unstable. So now we have not done anything else. This is how the vessel is right at this moment. And right now, as you have rightly said, we really need to tackle the left main further. And our aim is to tackle it with a scoring balloon. After that, we plan to take our IVUS catheter and have a look at how the scenario is. And obviously for this kind of complex lesion preparation is absolutely mandatory. And the LCX, as you have already pointed out, doesn't look that bad. So our aim is to prepare the lesion very well, have a look with IVUS, and then we want to do a provisional stenting, starting from the ostia of the left main going into the LAD. So now we are taking a scoring balloon, 3 by 10 millimeter scoring balloon. And with that, we want to tackle the left main.
Madam, assalamu alaikum. I'm Dr.
Walaikum salam.
Ji, madam, I have a question, madam, for because lots of fellows are joining in this meeting. So
What?
Fellows, junior colleagues and fellows are
Of
joining.
course, we wanted all our fellows to join. I mean, this was a program that was set by Mustafa Zaman. Our fellows have already joined, and we would be delighted for all of you to all the fellows to join as well. And I would request all the fellows as well as people starting their career in intervention to join our fellows course this year, because it will be I think a very great, good experience for everyone. Now, as you can see, the lesion is quite, so it's the balloon has gone. We're going to go
what
down
is the size of the
Yes, madam, I have a question, madam.
3 by
What
10.
catheter is preferable
3 by
in this?
12 NC scoring balloon. So we've gone up to 14 with this.
So,
16.
Dr. Asad, what is your question, please?
My question is, in that type of very severe left main osteal disease, which catheter is preferable for procedures?
Very
For the
important, especially for fellows. Ma'am, regarding catheter, do you want to mention what catheter you are?
This is a EBU 3.5. This is a EBU 3.
No side hole.
No side hole.
Yes.
There's no side hole.
Lot of strategy.
So now we are going up to 20 atmospheric
for
pressure.
the
Okay.
junior fellows. Number one is which one, right or left, that was already discussed, but maybe some junior fellows may ask elaborately, they can ask the question. And the wire crossing was very important. Catheters, which catheter should be actually good in this case, and about rota, scoring balloon, everything is actually very, very important. And a lot of senior cardiologists also with us. If they can give some their thoughts, we'll be happy.
Let me take a cusp.
Professor Jair sir is with
I
us,
think
sir. Can you hear me, sir? Professor Jair sir. Professor Abdul Jair. Sir, I think you are muted, sir.
Professor Mir Jamal sir, you are today's special guest. We'll discuss later. But if any question or any, you can add something in this case, Professor Mir Jamal, Professor Mohammed Jaman sir, and Professor Sorabujaman.
Here, I'd just like to point out that we went up to very high pressures with our scoring balloon, even up to 24 atmospheric pressure. And as you can see, the balloon is quite bulky, and it became quite bulky, and it got entangled with our LCX wire, and it was pulling the LCX wire, but we repositioned our LCX wire. So, keeping track of your wires when you're using multiple wires, and also, getting your very bulky scoring balloons out can sometimes be a bit of challenge, and you really need to be extra careful when you're doing that. That's for those of us who are starting our careers in intervention, and also for those of us who have been here for quite some time. I mean, it's always good to be vigilant. Now, as you can see, we are using minimum amount of dye. Hardly any dye is anytime required, because for wiring the vessel, you don't really need dye. The calcium is enough. For doing rotablation, you do not need the calcium guides you. And also, now we're taking our IVUS and having a look at what has happened so far. So now we've already done rotablation with a 1.5 burr, and we have done scoring with a 3 by 12 NC scoring balloon. We've gone up to 22 atmospheric pressure. And now we hope that our IVUS catheter will go very easily. And as you can see, the IVUS catheter is going fairly easily. and we take it down. Right. So here you can see very significant plaque burden. Yeah, here we don't have any calcium, but let's go up a bit. So maybe this would be a healthy landing zone for us. Let's see. So here we see the calcium, right? We see the calcium from like 7 o'clock to 12 o'clock, almost 1.5 quadrants, almost 2 quadrants. And here also there's a lot of calcium, and it's encroaching on the lumen. Here we have almost a horseshoe-shaped calcium that we have managed already cracked with our rota and scoring. And here you can see that at 11 o'clock position, we've cracked the calcium, but it's superficial and quite thick plate of calcium. And the lumen is quite tight at this part of the lesion, but we've done a fair good job. It's 270 degrees of calcium. Here also you can see the calcium. And here we get a branch coming, maybe a small diagonal or something at 5 o'clock position. Or no, it's there. So here we have fibrotic plaque.
What about the ostium of the LCX, ma'am?
No, we have not as yet crossed the L6. We're coming to the L6. If you have a look at the angiographic, then you will see. So here, this is LCX. And unfortunately, there's disease in the LCX ostium. We were very optimistic about the LCX, but as you can see, there's some fibrotic soft plaque at the root of the LCX. You can see that, right? It's at 3 to 4 o'clock position. There's plaque there. And yeah, so, but it's not calcific. Now this is left main.
Professor Shadul
This is
Banerjee
left
with
main.
us, Dr. Shams
is
Manohar
left
from
main.
Evercare. And,
Fibrotic. And this is the left main, very tight, this calcified lesion. You can see the calcium and left main, and now we are in the catheter. So that was quite some disease we saw, right? So maybe we can take an angio now. Give a bit of nitro and take an angio.
Do you like to take the IPAS catheter to the LCX?
You want to take the IVUS catheter in the LCX? I don't think that's required. You will saw
Yes,
the
yes.
ostia of the LCX is diseased.
Yes.
Let's have an angiographic view now, right? So we've done rota as well as a scoring balloon. That's all we've done. But the lesion in the ostia was very severe. And you've seen the 270 degrees of calcium, and thankfully we've managed to crack some of it.
Dr. Asad,
Yeah.
any comment, please?
No, it's good. Excellent job, madam is doing very nicely. I have a question in favor of fellows. May I ask a question, madam?
Yes, please.
We have seen that you will start with the rota. It's possibly 1.5 bar.
Yes, 1.5 bar.
So I have a question here. Should we proceed without the rota in this cases? In the center?
So I think in this case, there was a 99% lesion in the ostia of the left main. And if I had taken any type of balloon there, right, I would have totally obstructed the lumen, and I would have pushed and prodded. The balloon would not have gone, and the patient would have crashed. And if this patient crashes once, it's very difficult for us, right? So in this kind of severe ostial left main disease, I think rota would be the best option. You just go very gently, you do some plaque modification, and after that you take whatever other tools that you need. Here we took the scoring balloon, and now we've got a fairly decent lumen. the pressure and everything. One can have a look at the hemodynamics. He's tolerating everything very well. We do not have any inotropes on. Just a yes, so he's doing well. Touch wood up till now, and now we've already done a bit of measuring. And what's the area? Okay, so our distal landing zone is the area reference area with the diameter is 3.2, and the area is good. It's 6, right? So the healthy landing zone that we relatively found in the distal part, the area is 6.4 or something. So very good. Now, if we go to the maximum tight spot, I think it will be very narrow. So it's
already Professor Mir Jamal Chaudhary Sir with us, and he's also a special guest to this program. And I would like to request, sir, please. We know that Madam is going to go single vessel strategy from Letmin to LAD, but the ostium of the LCX is little plaque we have seen, but Ivas will guide us. But in case of suppose there's a more plaque in the LCX ostium, then what should be the strategy? Though Madam will answer, but I would request for the junior fellows, Professor Mir Jamal, sir. Are you with us, sir?
Sorry, sir. Sir, একটা meeting আছে, sir.
Okay. Professor Fazila, Madam, can you explain for our junior fellows if
yes.
ostium of the LCX is more severely diseased, then what should be our strategy?
So here, as the plaque burden is not excessive, we are going for provisional stenting. But if the plaque was very significant in the LCX and according to the definition trial, then we would go for an upfront double stent technique. And studies have shown, especially the DK Crush 5 trial has shown that DK Crush is the best technique, double stent upfront technique. So we would go for that. But here we are going for provisional stenting. So we hope that we will get away with a single stent strategy. However, if double stent strategy is required, if there is significant plaque shifting after deployment of a stent, we will go for a double stent technique at that point. And options would be a culotte or a tap here, right? But if it were an upfront decision for us, we would have gone for a DK Crush. So we've taken our stent, a 3.5 by 35, which a 3.5 by 38 millimeter stent, and this stent would allow us for selective expansion. So in the left main, we will expand it with a 4 or a 4.5 millimeter balloon. So we need to position, and for positioning, you can always use a cuspal wire, or you can also have a look angiograph. Of course, you'll have a look angiographically. Please dive, please. You need to push a bit. Check. Another bit of pushing.
So this is very important view. Allocranial is the important view to visualize the left main ostium, and for placement of the stent covering the left main ostium, this is the best view. And for RCA, iliacaudal is the best view to cover the ostium. Yes, and always try to keep for the fellows, always try to keep the catheter on to 2 millimeter away from the stent.
Push a bit more, right?
Yes. Regarding catheter, Dr. Chavan is asking regarding which catheter is better. Definitively, for osteolation, for alignment, this is the EBU or XB is the better catheter. And if you, in other circumstances, maybe Judkins left is helpful when the left main ostium is good. Because chance of injury to the left main ostium is least with the Judkins catheter. But for better backup support like these cases, you need a lot of pushing power is required to put the stent inside.
Check, please.
So this gives the better backup
Now we're
support.
perfect. Yeah. So
And
now we're happy with the position.
I think so for the beginners, in case of severe left main ostial disease, Duplin's left should be the preferable catheter.
নেমে যাও, নেমে যাও, নেমে যাও। নামো।
So how much pressure the stent was inflated with?
We went up to 14,
14.
and
So
then
now
now we've pulled back our balloons and we are
And-
going up again.
how much? 18 ATM, eh? Now you are
This is
going
what
to
came
18.
out, no?
Gelled wire, someone is asking about the whether you like to keep the gelled wire or you like to remove it, madam.
Here we've kept the jailed wire.
Yes,
We will remove it once we have a look and see how things are.
exactly. And
This is
as
an-
long as the gelled wire is there, that wire is outside the stent.
Yes.
So you should not push or engage the catheter in the ostium. That will distort the ostium stent. So outside the stent, as long as the wire will be there, the catheter non-selected.
So now we are taking a 4.5 by 6 millimeter NC balloon for doing proximal optimization. And we haven't, as you see, used any dye up till now. The pressure, everything is fine.
So as
So,
per IVUS, what was the diameter of the left main, ma'am?
The IVUS was the maximum diameter is around 6 millimeter. It's quite a big, large vessel. It's a big vessel. Almost 5 point. This is a struggle. This is a
Now proximal optimization with 4.5
balloon?
into 6 millimeter balloon, I think, ma'am.
So I'm taking a larger balloon, a 5 millimeter. Let's see.
Do you like to post dilate the LED also, or after
We
what do you like to do the
once we've secured the ostia
left
part of
vein,
the
yes.
stent, then we'll do, obviously,
Yes,
we'll have
yes.
to do post dilatation. This is a very long stent, a 38 millimeter, and no way will the stent struts be properly opposed without post dilatation. So post dilatation is absolutely mandatory, and if we do not do a proper job, there will be the risk of malapposition or under expansion, which can lead to.
Your question,
Assalamu alaikum,
please.
madam.
Check,
I'm Dr. Subhas Subedi, a phase B resident of BSMMU. I would like to just know about the proximal optimization technique here in this particular case, where there is aortoosteal lesion. Is it different from the proximal optimization technique, just distal lesions?
Excuse me, sorry, I missed the question.
Very important question, madam. Our phase B resident asked about the proximal optimization therapy of the port in this scenario, especially where there is late main and bifurcation. So it's a different technique for port in this scenario. Here,
We're doing what?
very important question.
We're doing proximal optimization now with a 5 millimeter, 5 by 8 millimeter NC balloon. And we've gone up to 14 atmospheric pressure. So this is our proximal optimization. You have to do proximal optimization.
What is the stent diameter, madam?
The stent diameter was 3.5, but it will expand up to 5. So now we've
And for side branch crossing or recrossing to the side branch, proximal optimization is very much helpful in these circumstances. Otherwise, if you go to wire the LCX, there is every possibility the wire may go outside the left main stent, and that might be the catastrophe. So after proximal optimization, it is easier to recross to the LCX, and there is less likely that wire will go outside the stent. So EBC always they emphasize on the proximal optimization very much.
Because
And placement of the balloon, that is the neck of the balloon or shoulder of the balloon, should be just at the level of bifurcation, should not exceed the bifurcation lesion to the LED. So if it is done perfectly, that usually open up the ostium of the LCX. But if the balloon crosses the LCX, that will produce the plaque shifting to the LCX.
Madam, have you any experience of using the
Yes,
ostium
if
bed?
the balloon size is more than normal size, it may hamper the ostium of the LCX or LED. So usually small size balloon, but with good caliber size balloon is very difficult to get sometimes in our cath lab. But at Heart Foundation, I've seen all type of balloon is available. This is very good for interventional cardiologists, but every cath lab actually devoid of this type of short balloon, but good caliber. So main thing is question is, if the balloon size is already Dr. Ashok mentioned that if cross the LCX ostium or LED ostium, that may hamper the both ostium, and that is actually sometimes troubleshooting actually created. So we always we should concern about in this regard actually.
Here is an important point. While crossing the wire to the side branch, if the intention is to do decay crash, it should be in the proximal strut, through the proximal strut. And she's doing like that.
No, we cannot do DK crash
Oh,
here.
this is
That intention is
provisional.
already finished, right? Because this
So
is
this
a
is
provisional
provisional.
stenting. Only when it is upfront, then you think about DK crash, because in DK crash, the first stent that is deployed is in the side branch. And for other provisional stentings, we have to do it from the left main to LED. Here, I wired actually from the to the distal
Distal.
strut. Yes.
Distal start, yeah.
Yes.
And in this scenario,
Now we're just doing
what is mandatory always? What is mandatory in this case, and to expansion the cell size, and sometimes recrossing may be needed.
So LED balloon, diameter of the LED balloon, ma'am, is it 3.5?
it is a 4 millimeter.
LED
by
is
12.
with 4 millimeters.
Professor Amol Kumar, we have
Sure.
seen. Chaudhary, can you
Thank
add
you,
something?
Mustafa Jaman, for inviting me. Can you hear me?
Yes, we are hearing you.
Sorry, I was interrupted for 10 minutes. I was in another meeting of my institute. No, so sorry. But I saw the case. It is a very nice case, distal bifurcation lesion, and madam is there. So what strategy and how we'll do it is madam very nicely already described, and I think all the colleague, including me, also be benefited from the experience of the madam, because Fazila madam has a large volume case done of left pen. So thank you, Jaman, for inviting me.
So this is active ops.
So now we've done post dilatation of the LED stent with a 4x12 NC balloon. We now want to do a kissing for the two,
Kissing.
the LCX and LED. Now about kissing, there's quite a bit of controversy. When you have a double stent strategy, obviously kissing balloon inflation is mandatory. It's a very important step. But when it's a provisional stenting. I mean, some authors have concluded that it should be done, whereas others have negated it, have said that it doesn't really impact. But here we will be doing kissing because we did see some plug in the ostia of the LCX, which very gentle kissing. We will not go up to very high pressure. And the plan is to use 3.5 by 12 for LAD and 3 by 12 for LCX.
So how the angiographically, how the ostium of the LCS is looking after doing the,
It looks fine.
it's look
It
fine.
looks fine, yes. We can show you. So we
Professor
are-
Abdullah Chaudhary, we've seen. Would you please add something, Professor Abdullah Chaudhary?
I have just joined. Let me see and I'll talk later.
This is 3.5, so I'll go. This is 3. I think maybe we need to open up the strut first with a smaller size balloon, huh? 3.5 might be a bit too large to go initially. Yeah.
So initially 3.5 will not go through the
Maybe I
strut
will
to the
open it.
LCX.
We'll open up the
So,
strut
yes.
first.
So it should be opened up with the 2 millimeters balloon. Then for
Do that.
kissing LED, you dilated with 4 millimeter balloon. So for kissing, madam, what should be the size of the balloon? Is it 4 into 3
No,
like this?
Well, there are lots of formulas, right? The Murray's, Finney's law,
Yeah.
Murray's law, and all those. So the thing is, we have chosen a 3.5 for the LED and a 3 for the LCX.
LCX, yeah.
LED.
So 3.5 in the LED and 3 in the LCX, total
Yes.
7.5 into 2/3. That is around, that is 5 millimeter in the left main. So again, you have to do the pot with the 5 millimeter balloon left main to make it the circumference circular. Report, yeah.
And angiographically, actually, LCX ostium seems to be very tight. Should you think of dual stand, double stand strategy, or by only the provisional stenting?
Maybe we got under outside the strut.
So other way that look for the LCX, it is said if it is more than 70%, you should you may go for double stent strategy. Other way, just you can do there is OAT. So if you take the pressure in the LCX, and if FFR is not significant, we can leave it alone.
It is auto size.
And in other branch, like diagonal, when the side branch is diagonal or OM, in that circumstances, even up to 90% of the lesion in the side branch ostium, you can keep it alone if there is TIMI3 flow.
Hey, let me get this balloon out also.
Thing is, why we are giving so much importance to TIMI3 flow is that in angiography, we are seeing a two-dimensional view, but the orifice ostium is a three-dimensional thing. So TIMI3 flow actually means that though you are seeing in one profile is narrow, it may not be actually the actual ostial size may not be that much narrow.
Exactly, sir. Exactly. That is very true. Because we have seen many patients in on view, it looks like 90% lesion, but patient is asymptomatic. How the flow is going to the distal circulation. Definitively, there is good lumen. So
Negative.
I think in this scenario, FFR also, because of FFR is very important. IVAS is on imaging technique, and FFR not imaging, but physiological studies. So for this treatment strategy, FFR is better than IVAS in this scenario.
Because yes, exactly. Because 2 stent, if you put a second stent in the LCX, chance of stent restenosis, chance of thrombosis, and longer duration of antiplatelet, all these 3, if you consider, in future, and LCX is not dominant here. If LCX is dominant here, then the scenario may be different. Here the RCA is a good vessel, LCX is co-dominant. So in these circumstances, LCX physiology is more important than the anatomical narrowing of the ostium. And Leppmann to LAD is main target to keep it perfect for longer period of time.
Also, the purpose of doing kissing bearing angioplasty in that situation to make it more circular, the side branch. This is very important.
So now, ma'am, are you doing the kissing now?
Yes, I'm doing kissing. So we did sequential and now we're doing simultaneous. So we finished our kissing.
Is it your regular practice to do the sequential,
actually,
then simultaneous kissing?
Usually we do sequential, and actually EBC main also encourages that. And I think we get better results because your Achilles heel is your LCX, and you really, so we do sequential and then we do
So in
simultaneous.
these circumstances, sequentially, if you do, which balloon you will inflate first, LCX or LED balloon?
LAD.
LED first, then LCX, then simultaneously.
Yes.
Yeah.
Yes.
Thank
Now
you, ma'am.
we'll do a report.
Then report is the final step here. Do you like to do the IVUS after?
We do an
Yeah. After doing the port.
Yes, of course. After report. So this
Yes,
is
the
the
left vein is quite big, and that's a relief. Sometimes we find a left vein that looks so small, and in those cases, I really wanted it without IVUS doing stenting on those cases is very dangerous.
So let me show you the left main when we first started. It was very, very small. We've managed to sort of let it grow up. Yeah, so
It's so
this
big.
is the left main. This is the
That's
left
the
main that
beauty of
we started.
IVUS.
So
You
we
can
can
make
see
a
the
five diameter left vein. That's nice.
A 5 yes, so it was like a subtotal left vein occlusion, almost 100% occluded.
My God.
It slipped a bit. It slipped a bit.
There is one question from here, madam. LCX, as there is plaque, we have done the kissing balloon. Now, is there any help will come if you give a drag eluting or drag coated balloon in the LCX ostium?
Yeah, of course, that is.
Madam, we know you are using
That's
drug
a
balloon.
great idea. I mean, you could do that. Let's have a look. But I don't think we have a 3 millimeter drug coated balloon right now in our shelf. So if we had, I think that would have been a great idea. So let's give some nitro and take a photo. And then we'll do the final IVUS.
So for the fellows, drag coated balloon, now with sirolimus eluting drag coated balloon is very much helpful. Such circumstances, so in the side branch is diagonal or OM, vessel is 2.25 or 2.5 millimeter. In other circumstances, small vessel, long diffuse lesion, or high bleeding risk patient, you need the surgery within emergency surgery. So that circumstances, drag eluting balloon is an excellent tool.
It's a very important thing. I think everybody actually will learn something from this case. From Bogura, Professor Shodulak, we are seeing, are you at something?
Thank you, Dr. Mustafa, for giving me the opportunity to observe these excellent demonstrations by Professor Fuzla Madam. One thing is that in case of professional stenting and the left main severely diseased and LCX was osteal lesions, in case of positional stenting, if the patient is not symptomatic after implantation of the stent in the left main to LED, and if we leave the LCX alone without second stenting, what will be the results? If we don't put any stent in the LCX due to lesion in the ostium.
Suppose there is severely now the LCX lesion here, the LCX is looking good, but if the LCX is very tight lesion, what would be the consequence?
Yes,
In this.
Do you want to see the our IVUS results? So here, of course, that is our plan. We do not plan to put any stent in the LCX. Actually.
Yeah.
It's a plan. So yeah, as we've already seen there.
Because there is no pinching, or there is no block, or there is no pinching of further pinching of the LCX after stenting. So why you just put a stent in the LCX?
We are not putting any stent in the LCX up till now. That is, we have not as yet put any stent, and neither do we plan to do as up till now. The plan is for provisional stenting.
Okay, provisional.
Yes, that is our plan.
Okay, Madam, and first question, it was a very high risk patients, late main disease, right ostial lesions, LCX lesion. Why we are not doing bypass surgery rather than stenting?
That's another ball game. I mean, there is this term called CHIP, right? So the complex high risk indicated PCI. So left main PCI, which is considered conventionally high risk, is done routinely in many centers, also in our center, and we have a wide experience with left main PCI. We've done more than 3,500 cases so far, and the thing is, in this patient, there were multiple factors. One was that he was not at all keen to do bypass surgery, and we felt that we could offer him an alternative option. Also, the other thing was that he has CKD. He's got interstitial lung disease as well as some COPD. So that was also an issue with the anesthetics. So all things together, we felt that we could do a decent job with a PCI.
Thank you. Because in our small center in Bogra, where we are doing in the periphery, especially during angiogram, when there is a left main disease or ostial lesion, even during the procedure, the patient may suddenly complain of chest pain, and sometimes there is hemodynamic instability. So we are really fear of doing PCI.
Yes, of course.
Yeah.
It goes without saying, but touch wood, we in our Heart Foundation, we have a great team.
Yeah.
Working together for many years, and we actually started doing left main PCI on a regular basis since 2007. So now we have almost 16 years of experience of doing left main PCI, and it's almost the same team, almost a very few operators, and the technician team is also the same, that the core group that works together for the left main. So we, inshallah, think that we have the experience and to do a left main case safely. So that is something that I think is something that we believe in doing, and we always try to do our best for our patients, and everything rests upon God, and with God's grace, mashallah, our center has been quite successful in left main.
Very true.
Thank you, ma'am. Really, Heart Foundation is doing well because we have all the facilities there. If there is any emergency, you patient may go into sent to the surgery department. So I think you can do everything. But in the periphery, what we are doing with limited facilities, we cannot take this risk because of lots of problems.
Yes. Shahidul bhai, I have just one suggestion regarding when the left patient, especially ostial left main or mid left main, patient become unstable hemodynamically unstable. This patient usually does not give you opportunity to shift the patient to the OT and make the OT ready for opening the chest.
Okay.
So whatever the situation is, if you have got even bare metal stent, if you put the stent from the ostium of the left vein to the LAD, that may be the mid LAD or proximal LAD, wherever you go, even if it compromises the LCX, patient will survive. Then you can send the patient for surgery later on. So save the patient first with suboptimal result, even with suboptimal result.
Thank you, Ashok.
Actually, if rotor not available in these circumstances with heavily calcification, this patient remain stable because angiogram was done outside.
Yeah.
Patient is stable. Today again we relook the left vein. So usually so much calcified lesion, patient stable blood. So likely this patient will become suddenly.
It's just, but 3 days before we did a angiography, this like a patient, and there was non-selective angiography done, and there is osteal of the LAD, and also distal part of the left main also disease, and left main osteal also disease. And though that we sent this patient for surgery, but it's very complicated case. Sometimes we face during our angiography procedures.
Actually, this
Sir,
patient also became
sir.
unstable in Sylhet. Okay, so actually this patient became unstable, and the operator called us and said that he's sending this patient on an emergency basis, and could we do a PCI ASAP, as the patient was not keen for surgery. So he came actually yesterday evening, and he got admitted, and today we are doing this case. So yes, this patient also had his angiogram done maybe 1 or 2 days back in Sylhet. He became unstable. He was shifted here, and we did the PCI.
Thank you, madam.
That is very common.
For your brilliant.
Get unstable after angiogram. That is quite common. Now, about the left main results, our left main area is 13 square millimeter now, which is mashallah very good. And the LAD proximal is also like 6.7 millimeters. So I think this patient will do well with this result. The struts are well opened, well opposed. There's no malapposition. And I think we are happy with this result.
Any special care should be taken after procedure in the post?
In this type of, when we after a rota, it is customary for us to do an IVUS immediately, just to exclude any kind of pericardial leakage. But here we were very careful. But still, you will do an IVUS. You will check an ACT to see, and we've already checked the OCT as the procedure was getting quite prolonged, and the OCTs are 350. 312 was ACT was 312. So you check the ACT, you do an IVUS, and you of course follow the an echo. Sorry, you do an echo to see whether there's any pericardial effusion. You do an ACT, and you follow up the patient in the CCU. And the ECG and the hemodynamics of this patient, as you can see, if you go to the, it is stable. Can we have a look at the ECG, please? Just show the ECG. Rana, show the ECG. Yes.
Okay,
so
good.
Yes.
Very good.
Madam,
Will you give him heparin in CCU?
10,000.
Today?
We gave.
Not paraparity, in the CCU.
In the CCU,
Oh, in the
usually
CCU,
this case does not need heparin actually.
Anything else? This is it, finished. No heparin.
Professor Mir Jamal sir, he's our special guest today. He's also with us, and actually he's Secretary General of GSA and Director of NICVD, renowned interventional cardiologist of Bangladesh. Sir, are you with us, sir? Sir, are you hearing us?
Thank you. I'm extremely sorry that after starting this meeting, after starting this work, and then and there, I have to rush 2 meetings and completed the 2 meetings and then come back. So I have not seen anything. However, I know what Professor Fazila Malik has done. That must be an excellent job. I have seen it. my congratulations is on that part that she has accepted our proposal, your proposal, and she has done this work. And this is the thing that is why we like her very much. Whenever we call in any program, scientific program, in any sorts of job in scientific program, she is with us. And that is why we are grateful to her. And my thanks and gratitude to her for doing this work. Thank you, madam. And thank you, Dr. Mustafa Jawan, for arranging this program.
Mir Jamal said, I am Dr. Ashok Datta. Congratulations, you, a great congratulations for your great success in the last 2 days radial program.
Thank you. It is for you. As you, Dr. Professor Ashok was up to night 8 p.m. They my credit that I could be able to keep you up to that time, and you gave that time, and that is why I'm grateful to you also.
So thank you, everyone. And before we conclude, let me introduce our team. So I'm here.
Madam, we have another some question, then we'll
Yes.
suppose I have experienced this case a few months back. The patient was very young, but during procedure, there are some arrhythmia and few arrhythmia and bradycardia. Then we started from right side. And after establishment of the ECG, then we go the left side. But you have started from left side. So when we started from first left side or when the right side, just again
so
in this scenario.
Mustafa's question is, if you have got, madam, right-sided titillation as well as left main, which one you will tackle first, right or left?
If you look at yesterday's case, I don't know who were there yesterday. In yesterday's case, that was also a multivessel disease. That was also ostial left main and heavily calcified LAD. So in that, that was a RCA was a CTO. And that RCA was, even though it was a CTO, it was getting collaterals from the left side. It was getting collaterals from the left side. So yesterday, we actually did the RCA first, and we did it 3 days ago. And we tackled the left side in front of the audience as a live case yesterday in Professor Mir Jamal's program. So that was also a left main. And today, we did the left side first, the right side we plan to do later. Now here we did the left side first. Here the RCA was sort of the only vessel that was, like getting some supply into the myocardium. The left side was so severely diseased, it was like almost a subtotal left main, 99% left main disease. So here, if we tackle the basic lifeline for this and maybe we can get away with it, do it smoothly. But what if the patient crashes? If the patient crashes here, then we do not have any support from him. The left side is 99% occluded. The right side, which was a stable plaque, we have already disrupted it and made it unstable, and now he's unstable. We could not salvage the patient. So here, today, our choice of vessel was the left side, the subtotal 99% occluded vessel. Whereas yesterday, similar situation, triple vessel disease, our choice was the right side, because the right side was getting collaterals from the left side. So we fixed the right side first, and that allowed the left side also to breathe a sign of relief. It didn't have to give collaterals to the right side. The right side was also supplying a lot of myocardium once it was properly revascularized. So the answer to this question is that is what makes intervention so interesting. There is no absolute right or wrong. The interventionist looks at the whole bigger picture, and the team works together, and the team together decides on which vessel to tackle first, and you go along the way. And at that point of time, you do the best that you can. Maybe in hindsight, you might feel that, okay, maybe if I had done that, this would have happened. But at that point of time, you try to do your best. And I think that one of the best recipes for success is talk with your teammates and be on the same page and do what the whole team has agreed to do. And that sort of, will help you and guide you, because sometimes maybe someone is looking at this from one perspective, someone is looking at it from a different perspective, and when you share the knowledge together, the results usually work very well.
Then what you told what you told you, that means it depends on case to case as well as this.
Absolutely. The case to case, it varies. Your decision varies. Intervention is not an absolute science. It has a lot of art in it as well. And that is what makes intervention so interesting.
Another question, I know you will do the right side in the next setting, not the single setting. So can you perform in the single setting, or why not?
Disturbing.
We can perform in the single setting as well. This patient tolerated this side very well, and the dye use was also very minimal. And we can perform for this patient. His ejection fraction is also good. So for him, the only issue would be that his serum creatinine is a bit high, on the high side, 1.5. But we didn't use that much dye. Also, we've used up till now, I think, 100 ml of dye. So for him, yes, we can do. But where would we stage the procedure? Like for the patient yesterday, we had opened up a CTO. Now, touch wood, if something goes wrong with the CTO and then you're doing a left main, then you're in a big trouble. So for that patient, we staged the case. Patients who have poor ejection fraction, we usually stage the procedure so that we give the patient some breathing time. Poor ejection fraction is the worst thing that your patient can have, because if a patient with poor ejection fraction crashes, it's very difficult to help them. So for poor ejection fraction, patients with very high serum creatinine, today we'll be doing a case, her serum creatinine is 5.9. We will definitely stage the procedure, and Ishraq might need to do some dialysis as well. For CKD, poor ejection fraction, very frail patients, very elderly patients, we usually, or very complex disease, long procedures, we usually stage. But for this patient, yes, we can do the right now.
Thank you, ma'am. So other thing, when you do the rota in on-site, that produce lot of ischemia and that side, because lot of powders, lot of materials, so it's going to microcirculation. So in that circumstances, other vessels should not be touched in the same settings.
I have another question. Already, if you use already rota, there may be cause of slow flow, no reflow, maybe complication, or may not be. But I feel that is another option. But which would be better in this scenario? We know the long lesion rota is good than IVL. But in case of discrete ablation or short lesion, in case of IVL is another option.
For this vessel, for vessels like this, 99% occlusion, the IVL balloon will not go. The
IVL will not
balloon
go.
is so bulky. Here we were even hesitant to take a semi-compliant balloon, because when you push a balloon, you cause ischemia, your patient might crash. So here rota was the only option. And also for very heavily calcified vessels, where the lesion will not permit even the balloon to go, IVL cannot be an option. You will have to do some plug modification with an atherectomy device, and then you can take your other devices down.
Thank you, ma'am.
Madam, you have introduced your team, then we'll.
So I'll introduce our team, right? So Abdul Qayyum, everyone knows him. Moshed, everyone knows him. Lipi, she's also, so it's a team, right? It's more like a family for us. Then we've got Niaz over there. Niaz, shamne asho, dekha jay na to. Niaz, who's been helping us with everything. Masood, our Tanzila, Russell, our technician, and we've got our anesthetist who kept our patient calm and quiet. And this is our Rashid, our anesthetist of the day. So the anesthetist, he is helping us today. So that's us. So thank you so much
for your brilliant presentation. I must congratulate you, and let's give her a big hands, everybody from the audience, and to your team also. And I wish success of your next program, 30th November to 1st and 2nd December. We hope that will be successful. And Professor Mir Jamal already completed a successful program on radial program yesterday. Everybody we enjoyed, and a lot of senior cardiologists they also joined with us. I'm watching Professor our giants sir, Professor Amar Kumar Chaudhary, Professor Jaman Abdullah, Professor Abdul Chaudhary, our Vice Chancellor already with us, Professor A.K.M. Raja. He told me over telephone that with some few patients in front of him, he is watching but could not join. So Professor Saurabh Jamal already with us, and from Bogura, Professor Dr. Shohidul Haq, and Dr. Ashok Datta, Professor Habibur Rahman, and in the audience, Dr. Chauhan, and from BSMMU, Dr. Kolimuddin, and some residents, and everybody with us. Everybody enjoyed the session. We must thank everybody, and thank you, Dr. Incepta and Abbott Vascular for as a scientific partner. They are with us. And again, a big hand to Madam, and I hope she will continue this type of educational program with us, and from Bangladesh Cardiovascular Research Foundation and the Department of Cardiology, Bangabandhu Sheikh Mujib Medical University, always Madam with us, and we will be with us, Madam, with you, with National Heart Foundation. Thank you, everybody.